Good evening, dear colleagues and friends. I'm Professor Konstantinos Triantafyllou from Athens, Greece, and I welcome you to this exciting event, our webinar, our Wednesday webinar. The title today, the topic is very hot. It's how to optimize post-polypectomy surveillance. And we are very lucky to have with us Professor Evelyn Dekker, Dr. Maria Pellise, and Giulio Antonelli to discuss this topic. As you already know, this is the third consecutive year that we run our webinars, and we thank the ESGE that offers us this opportunity. Thus, you have a chance to view high-quality presentation on the hottest topics from world leaders in endoscopy. You can also interact with the speakers and participate by submitting online questions. So please focus on the bottom of your screen where you have the Q&A tool where you can fill your question throughout the webinar. And of course, you'll know that these events are still free from the ESGE, offered from the ESGE. Now, in order to save time, it's time to welcome and introduce Professor Evelyn Dekker from Amsterdam, the Netherlands. Professor Dekker is a well-known endoscopist. She has not only published a lot of material on the polypectomy and on colon cancer screening, but she has also participated in multiple events. Evelyn, welcome.
Thank you very much, Kostas. So welcome, everyone. I'm very happy to be involved in this webinar tonight. I'm going to start a discussion with you on the post-polypectomy surveillance. So these are my disclosures for this talk, although most do not specifically apply to this topic. So as you know, colonoscopy is the reference standard for detection of polyps and colorectal cancer. And we also know from the National Polyp Study from the United States that indeed, when performing colonoscopy and we remove at least one adenoma, the patient is protected for colorectal cancer. Actually, the black line here showing the cumulative colorectal cancer mortality versus the years followed the patient up, you can see that is the background population in the USA, so the SEER population, and you can see that having at least one adenoma removed protects the patients for almost half of the deaths. So ideally, of course, we would like to have the line here, but that might have to do with several quality issues because it's already a very old study, and also maybe by surveillance intervals. But we know by performing polypectomy, we at least do something good, but of course we want to do better. However, colonoscopy, although it is the gold standard, also has disadvantages. It has, of course, as you know, a burden for the patient to undergo a colonoscopy, but it also has a bleeding rate, a perforation rate, and actually there's even a small, very small chance of death after colonoscopy. Besides, it has a big burden for healthcare and for doctors because we need to do all those colonoscopies and also they have to be paid for. Besides that, when considering surveillance and the optimal surveillance strategy, it should be recognized that at the moment, most Western countries have already implemented a colorectal cancer screening program. So for patients not undergoing surveillance, there is the national or the regional screening program already in place once they are in the target age. So that means, again, if we discuss surveillance, we need to really carefully weigh the benefits versus the risks and the advantages. And regarding that, I think it's very important to realize that the most important outcomes are colorectal cancer incidence and mortality. So not just detecting one small adenoma as an important event, because that might never have grown into cancer. So that's not what we aim for at colonoscopy surveillance. We want to reduce incidence and mortality. So when assessing or when estimating the optimal surveillance intervals, that should be ideally based on two things. One, on risk of having left polyps in situ during colonoscopy. And of course, that has to do with the quality of the colonoscopy performed, the number of polyps detected at colonoscopy, and also, once all the polyps are removed, the completeness of that removal technique, because when having left a part of the polyp inside you, of course, that might grow into cancer again. Something on the quality, of course, there's a lot of awareness. In the past, I would say 10 years, everybody realizes that the quality we perform the better the quality, the smaller the risk for post-colonoscopy cancer. And that definitely has improved quality overall in Europe and worldwide. However, that also comes with detecting more and more very tiny and small polyps. Also with the increasing, all the improvements of the quality of the high definition endoscopes, we see more and more polyps. And removing more of those tiny polyps doesn't mean that we need to reduce surveillance intervals, because that would be kind of counterintuitive, right? Performing a really high quality colonoscopy, removing a few tiny polyps more does not mean that we have to look more often. Besides that, we have to realize that we also look for the developing of new polyps. Actually, if the quality of the colonoscopy is optimal, everything is gone, still there is a chance of the patient having a new polyp, so metacrinous polyps after all. And then we have to look at the pathways of cancer. How soon can that happen? Well, we know for the adenoma carcinoma pathway, traditionally, it takes very long. We don't have a lot of data. It's only old observational data, but we think that on average, only 1 in 20 small adenomas will ever develop into cancer, so a very small chance, and that it takes also very long for such a polyp to do so, at least 10, but more probably 15 years. There's of course one exception, we all realize that, that's the Lynch patients and some sporadic microsatellite unstable cancers where probably the adenoma carcinoma pathway is quicker, 3 to 5 years. So we have to identify those patients at risk for such a cancer because they might need a specific surveillance scheme. We also know, and it has become clear in the past decade, that also sessile serrated lesions might develop into cancer. We don't know a lot about the pathway, but we think it must be around the same as for adenomas. So recently we updated the guideline that was written in 2013 with this whole group of ESGE members. And this is in short the guideline. Of course, we will, together with my other two colleague speakers, we will take you through the guideline step by step. The new ESGE guideline was developed by a thorough literature search in Medline, PubMed, Cochrane. The evidence was summarized in tables using the GRADE system, and then all the members that you saw as co-author in the paper needed to have a consensus for the new statements. So first, the quality of baseline colonoscopy. I told you why it's important, and we said, well, that's really where we start. If the quality of the colonoscopy was not good, the patient should not enter the surveillance scheme as I showed you just now. Repeat it if it's not good enough. When lesions are taken out piecemeal, there's of course a higher risk of recurrence, especially at that site of the maybe tiny little bits that are left after the piecemeal resection. And we know from studies that the risk is about up to 25%. Most of it is found at 3 months, but some is not detected at 3 months, but only later. So that's why in our new guideline, we advise you to perform a piecemeal, after a piecemeal polypectomy, to perform an early re-inspection of the scar after 3 to 6 months, but also realize that 25% of the recurrences are not seen at that time. And that's why we advise to perform another early surveillance endoscopy after another 12 months. So this is an example of a piecemeal EMR performed in this case, and this was what we saw after 6 months. And actually, this is why in another guideline, in the advanced imaging guideline, we advise you to perform such inspections of previous sites of polypectomy by advanced imaging techniques like BLI or NBI, like is done here. And then you can see, when you look at it more closely at the pit pattern, that this is just granular tissue and not recurrence of adenoma. How about the scheduling? Well, it's very important that both doctors as well as patients adhere to the advice of the surveillance interval. And we know from literature that adherence is probably just around 50%. Patients come either too early or too late or never, and that might be due to worries with the patient or the doctor or the family doctor, but also maybe because of ignorance about the given schedule. And that's why we advise that everyone should be informed well. It should be in the medical chart of the patient, both in the hospital as well also as in the chart with the family doctor. So if somebody should want to know the surveillance that was advice that was provided, it is refindable. So now I give the word to Maria to introduce the adenoma surveillance advices we give.
Thank you, Evelyn, for the nice introduction. And now it's time for Maria Pellise, one of my greatest friends and colleagues. We spent together more than 4 years in the governing board of the ESGE, working very, very hard. Maria is from Spain, Barcelona, and we're looking forward to hear you, Maria. Welcome to the event.
So thank you very much. It's an honor to be here with Evelyn and with Giulio and Kostas. So I will go into the part that is related with adenomas. Here are my disclosures. This is the main figure that we have to bear in mind for these new guidelines. And the first question, once we have assess that the quality of the colonoscopy was appropriate, the first question will be, is this patient require any surveillance? And this is something very new, and this is the first part we are going to treat, because I think that this is a new concept for many of us, because we used to think that anybody that had at least one adenoma in a colonoscopy should go to surveillance because this person had a risk of colorectal cancer. And this is not true. So this is something that has been clearly demonstrated, and I hope that I will convince you through the next slides. So the first thing that we have to bear in mind, and that was Evelyn already explained, but I wanted to emphasize again, is that our aim by screening and surveillance is to reduce the colorectal cancer incidence. It's not about finding polyps. This is not, I mean, many people can have polyps during all their lives and they will never have a cancer. So we are not, we don't care about having polyps. What we care is about having colorectal cancer. So our main aim is to reduce the colorectal cancer incidence. And this is what we have to have in mind when we are doing surveillance. So here is what you will read in the guideline. Those are the patients that are at no risk for having colorectal cancer, and they don't need to have a surveillance. These are those patients that have polyps, adenomas that are smaller than 1 centimeter, that have low-grade dysplasia, or those that have less than 5 adenomas with low-grade dysplasia and smaller than 1 centimeter. Those people that have that kind of polyps, they don't need to go to surveillance because they don't have a higher risk for colorectal cancer. And this has been shown in several trials during the last 10 years. This is one of them from Norway, where you can see here that this is the risk of dying from colorectal cancer. You can see here that those people that had low-risk adenomas had a smaller risk of dying from colorectal cancer than general population, probably because their polyps were removed. Whereas it's true that those people that had high-risk adenomas had a higher risk of dying from colorectal cancer. We can also see these same results in this trial from the PLCO group in the States with a 13 years follow-up, where you can see very nicely in this graph that those people with low-risk adenomas had the same risk of having cancer, of incidence of cancer during follow-up, the same as those people that didn't have any adenoma, and very different from those ones with high-risk adenoma. And again, you can see that again within this other study from the States, where again you can see that the two curves from the people with low-risk adenomas and no adenomas are very similar and very different from the ones with high-risk adenoma. This was incidence, and the same for mortality, as you can see here. When we look at mortality, those patients with low-risk adenoma have a lower mortality than the people with no adenomas. So it looks like having done this first procedure, this first colonoscopy, having removed the adenomas is a protective effect, and that those people don't need any other colonoscopy during their follow-up. So this risk of, this concept of no risk is well accepted now with all the guidelines, all the societies, and there is several consistent evidence in the literature. But also we have to bear in mind that the definition for low risk may be different in different guidelines and different studies. And this is something that needs still further evidence. And I just wanted to raise this point because I understand that many of you that are connected now, maybe from Europe or from the States or other countries around the globe, and that you probably have also your national guidelines. And what is important is that you have, after this talk, you have the concept of no risk introduced very deeply. So as you can see here, the ESGE guideline is very similar to the one from the British guideline. These are the three guidelines that have been published this year, but are a little bit different from the ones from the States in the question of defining which is a low risk group and what is a high risk group, and also in the intervals or the solution, the proportion, the intervals for surveillance. So you can see that our guideline, the ESGE, will say that those people with less than 5 polyps, less than 10 millimeters can return to screening after 10 years or return to a colonoscopy after 10 years, whereas in the States, this would be different. So, and on the other hand, we have to focus all our efforts in those patients that really require a surveillance. And who are those patients that really require a surveillance? Well, those would be those patients that have at least one adenoma equal or larger than 10 millimeters, or one adenoma with high-grade dysplasia in the irrespective of the size, or those people that have 5 or more adenomas. Those people are at higher risk of having colorectal cancer during follow-up, and that's why they need a surveillance colonoscopy, and that surveillance colonoscopy will be done after 3 years. This information, this is a very important paper. I think it's a very, very nice paper. It's something that everybody needs to read. This paper by Wendy Atkin, where they were analyzing the group that was previously assessed as intermediate risk group, which were people that had 3 to 4 adenomas, or 1 or 2 adenomas larger than 10 millimeters. They assessed this group, and they saw that in this group, when we looked during follow-up what happened, the cumulative incidence of cancer was high, was increasing, but you could clearly divide these patients into 2 groups. One group that was really at risk, that was that one, and another group that was not at risk. And what defined this high-risk group was the presence of high-grade dysplasia, lesions larger than 20 millimeters, proximal location, or a colonoscopy that was not well prepared. So we saw that the fact of having 3 adenomas, small adenomas, was not a risk criteria. And that's why we changed our criteria for this guideline. And as well, we could see here that the villus component was not at risk. So that was clearly stated that the high risk group is a very specific group. And this is what we can see in all the papers that I showed before, but in the other side, here is the patients that have a high risk group, that you can see that they have a cumulative incidence of cancer that is 2% instead of 0.5%. And this is a study from Poland that has been published very recently, and they even go one step further, because what they see as well in this study, as the one from Wendy Atkin, is that the risk factors for having a higher incidence of colorectal cancer during follow-up are high-grade dysplasia and lesions larger than 20 millimeters. So they propose to change the criteria of size, instead of 10 millimeters, to push it to 20 millimeters. And with this strategy, using only these 2 criteria for defining high-risk populations, we would do colonoscopies only in 10% of cases instead of 40% of cases, without increasing the number of colorectal cancers during follow-up. However, even if we have already this evidence published, the guideline decided not to push the burden to the limit to 20, because maybe it was not enough evidence to still, and it's a lot of changes, and we think that it's better to go bit by bit. So in summary, what you have to remember is that with respect with adenomas, those people that will require surveillance are those people that have 1 adenoma that is 1 centimeter or larger, high-grade dysplasia, or more than 5 adenomas, and they will need to have a colonoscopy in 3 years. Then also, as Evelyn has already stated, we have to bear in mind, especially for adenomas, but also for sessile serrated lesions, that those people with lesions larger than 20 millimeters that have been resected in piecemeal, they need this first colonoscopy after 3 to 6 months that can be considered part of the baseline colonoscopy to look at the scar and treat the possible recurrence that happens up to in 20% of cases. And then they need another colonoscopy 1 year after, that will be 18 months after the baseline colonoscopy, because even if in this first surveillance colonoscopy you don't find any recurrence, there is still a small risk, like 3 to 5% of having a recurrence in the late colonoscopy. So those people, they will need 1 colonoscopy for treating, another 3 to 6 months for surveillance, another 12 to 18 months. And if there is no recurrence, then they will go into the surveillance 3 years afterwards. And that's it for adenomas. I give the word again to Evelyn.
Thank you very much, Maria. So indeed, my next topic is the serrated polyps. So after Maria's very clear presentation, I hope to be clear as well, because you saw in her slides that she left out the part on serrated polyps. Well, these are the previous statements from the guideline in 2013, which were on the serrated polyps, which said that any serrated polyps less than 10 millimeter in size without dysplasia should be classified as low risk. And then the large ones or the ones with dysplasia were classified as high risk. So this is the evidence, the new evidence that we had on the low risk polyps. And you can see we have quite a vast number of data. I think this is a very nice example of data from a paper in gastroenterology of last year, where you can see, I think already in one easy site in this scheme, that the hazard ratio of patients with non-advanced adenoma is the same as those with small serrated polyps. So indeed, those polyps smaller than 10 millimeters. So it seems very logical to put those in the same risk category. So no surveillance. Adding to the group of adenomas that Maria just discussed with you, also any serrated polyp smaller than 10 millimeter without dysplasia does not require endoscopic surveillance. And then the new part of the guideline is that they totally go back indeed to the screening, which we have now in place in most countries. If there is no screening available, it is advised to repeat the colonoscopy in 10 years after the index examination. Actually, we already had some discussion on the return to screening, because I think it's still questionable when to be returned to screening, because I think there's no general advice provided in the guideline. So should they return immediately if you have a two-yearly fit-based screening program to have a fit in 2 years, or should they enter after 5 years or maybe after 10 years? I think we need more evidence there, and it might be nice for the discussion later. So this is again the new part of the guideline. So for the high-risk serrated polyps, there's also quite some evidence that is on the high-risk adenomas, high-risk serrated polyps, and also traditional serrated polyps. And again, I think it's nicely summarized by in the same paper by Hay, and it shows that those patients with large serrated polyps are in about the same league as also those with advanced adenomas. So what is a large serrated polyp? Well, probably again larger than 10 millimeter. There's no such studies as Maria explained to you about larger lesions like up from 20 millimeters like the Kaminsky group study. So this is when you look into more detail, the surveillance of the serrated polyps larger than 10 millimeter, you can see that this was indeed the only clear increased risk group of patients when you subdivide the serrated polyp increased risk for metachronous cancer. However, there's no data on dysplastic sessile serrated lesions, and you will know from the serrated pathway that we think that most serrated cancers develop from these dysplastic serrated lesions. And they are usually small, but they already harbor a very high risk part, that small dysplastic lesion. And they are uncommonly observed, although we know that probably at least 15 to probably 20% of post-colonoscopy cancers are coming from the serrated pathway. So that means that if you do epidemiologic calculations on that, and you think that the pathway is probably long, like in adenomas, it means that probably once the serrated polyps get a little focus of dysplasia, they probably very rapidly develop into malignancy. We don't have accurate estimations, but maybe within a year. So that means that those are clearly the probably most highest risk lesions of all serrated polyps. And this is an example of a small serrated polyp with already a tiny dysplastic lesion in that serrated polyp. And although it's small, it's definitely an advanced lesion. And here you can see again a very tiny polyp of about 1 centimeter with an adenocarcinoma in that serrated polyp. So I would like to highlight that whereas you know that serrated lesions are generally more difficult to detect, especially the sessile serrated lesions, because they're difficult to see in their pit pattern, the color is the same, it's difficult to delineate them. Usually the adenomatous focus in a sessile serrated lesion is quite easily seen, as you can see in these endoscopic images. However, if you don't look very careful, you might miss that around this small adenoma-like polyp, there's a larger sessile serrated lesion. Here, with MBI and a little bit more close-up, I think you can already better see it with the dark pits, the crypts enterings. And also, when you lift it with some saline with methylene blue, it becomes even more easy to delineate them. And I would like to highlight that this is the way you have to look at every polyp, at least this way. So always put your MBI on and to try to see such lesions, because those are, again, the high-risk lesions and need to be taken out radically. Because if you only take this part, your pathologist will tell you this was a dysplastic lesion, so an adenoma, and you will give the patient a wrong advice, because this is a really high-risk polyp. So we don't have appropriate surveillance data for specifically this group, but again, clearly this is a high-risk lesion. So in the guideline, we state that apart from the advanced adenomas and the multiple adenomas, also any serrated polyp that is large or harbors dysplasia, or indeed the traditional serrated adenoma, should have an early surveillance at 3 years. However, as I said, for this group, we don't have prospective data, but that is actually, for most of those studies shown, is all retrospective cohort research and not prospective data. And I would like to highlight that at the moment, we are running in Europe with many centers throughout the different countries, a prospective surveillance trial, including both low-risk adenomas as well as high-risk adenomas, and also serrated polyps, which is an observational arm, regrettably. The other two are randomized trials. So we hope to inform you. We are around the 3-year surveillance now. So we will need a few more years, but at 5 years, we will definitely be able to tell you the first results of this prospective trial. I give the word back to Kostas, and then to Maria, I think.
Okay, thank you, Evelyn. Maria, please take over.
I'm having technical problems.
So it takes longer now for the second surveillance.
Yeah, that's the second surveillance. So yes, now now that we know that, so those people that have less than 5 adenomas, less than 10 millimeters, all with low-grade dysplasia, or less than or serrated lesions less than 10 millimeters, they don't need any surveillance. The other ones, they will need a 3-year surveillance. And once we do this 3-year surveillance, what happens afterwards? Well, if after 3 years we do a new colonoscopy and we don't find any polyp required surveillance, then we can do the next surveillance at 5 years. And if then no polyps are found, then we can tell this person that he can return to screening in 10 years or have a colonoscopy in 10 years. Whereas if after this 3-year colonoscopy, we do find again polyps that require surveillance, then we will have to keep doing colonoscopies every 3 years. This is based on very little evidence, but some evidence that showed that it's true that the people that have polyps during follow-up, they have a higher incidence of colorectal cancer, so it's important to keep doing follow-up. Whereas when they don't have polyps, the risk is again the same as for the people without polyps. So this is what we have to do. That is a recommendation, even if the quality of the evidence is low. And then this is an important concept as well, because very often we keep doing surveillance, and those patients who are very prone to come to the doctor and they like to be very well surveilled, they will come forever to our outpatient clinic. But we need to bear in mind, as we were saying from the beginning, that what we want here is to prevent those people from having cancer and dying from cancer. So what happens is that when you are 18 years old, your probability of having a cancer in the next 10 years is probably not so important as the probability of having other illness, like cardiovascular disease or dementia or other illness that will be more important in terms of quality of life and also life expectancy. So also we know that colonoscopy has many more complications for older people. 80 or older people have more complications. So having that in mind, we have to remember that we have to stop surveillance after 80 years old, or for those people that have less than 10 years of life expectancy. And this is, I wanted to put this paper because this is another paper that has been published very recently from the European Society of Gastrointestinal Endoscopy. And I think that it's also a very important paper on when we don't need to do endoscopic surveillance. And this is, and in this guideline, we also state that those people with more than 80 should stop. And also I think that it's very useful very often to use this calculator, for example, that will help you to know if this patient, what is the probability for this patient to live more than 10 years, and to really help you to take this kind of decisions. On the other hand, there is another situation, it's those people that explain that they have a family history of colorectal cancer. Well, if those people they explain that they have somebody, a first degree relative, like a father, mother, or a brother, a sibling, or a son or daughter that has had a cancer before 50 years old, or if they explain that they have two first family relatives with colorectal cancer, then they need to go to genetic counseling to rule out Lynch syndrome. But if they just explain that they have an aunt or a grandfather or somebody in the family with cancer, 80 years old, 75 years old, we know for sure that these people don't have a higher risk than the rest of having a colorectal cancer, and they should go the same screening and surveillance protocols than people without any family history. So you don't need to change your surveillance with those people that explain a family history of colorectal cancer if it's not a first degree with less than 50 or 2 first degrees. But on the other hand, if the patient presents with 10 or more adenomas, cumulative or only in one colonoscopy, then it is important to send this patient to genetic counseling, or at least to a specific follow-up to see what happens in the first colonoscopy afterwards, because it can have a polyposis syndrome and he needs a specific surveillance. So, and this is the last slide. We wanted to emphasize that we know from this meta-analysis and from other papers that the adherence to guidelines is very low. Only 50% of patients do properly the surveillance. So it is very important to try to improve and do as better as possible the surveillance, because we have a high burden of colonoscopies, and we have to try to focus on those ones that are really at risk and give more opportunities for screening to the other ones. So this is it. Thank you very much to all of you, and we hope that you will come to the ESGE days, even if they are virtual. We are waiting you over there. So I give the word to Giulio.
Thank you, Maria. It's not polite not having already introduced Giulio. Giulio is one of the rising stars in our community, and Giulio has kindly prepared some exercise for all of us.
Thank you. It's a real honor for me to be here among such panelists and to talk about such an interesting topic. So I'll show you some of the clinical cases I prepared so we can have some real life situations we can discuss upon. So I have no conflict. The first case is a man of 56 years old presenting to our outpatient clinic. He has undergone 3 months ago a colonoscopy after a positive FIT test. And this is the report that we read. We read the non-optimal preparation in some colonic segments, 2 polyps detected and removed, 1 sessile polyp of the ascending colon, which comes out as low-grade dysplasia with free margins, and a 6-millimeter polyp of the rectum, which turns out to be hyperplastic. So this is the first question for the audience. Bearing in mind this report, which surveillance interval will you recommend to your patient? Okay, so what surveillance interval would you recommend in this patient? 1, return to screening. 2, colonoscopy at 10 years. 3, FIT test at 5 years. 4, repeat colonoscopy in less than 1 year. And 5, colonoscopy at 3 years. Wow.
Excellent.
So the small hint maybe helped, but we see that most of our attendants think we have to repeat colonoscopy in less than 1 year. And I think they are right, because if we go and have another look at the report, we see that there was this vague description of the bowel prep. And so is this actually a baseline high quality colonoscopy? Probably not. And to guide us and help us remind which are the components of a high quality baseline colonoscopy, the WEO 2 years ago issued a very useful checklist of quality in baseline colonoscopy. And we can see that among them, we have a checkbox for the quality of bowel prep that has to be reported using a validated scale and has to be considered adequate. As in this case, we have no validated scale, and it's even said that the preparation is non-optimal. We have to repeat colonoscopy in less than 1 year. I don't know if any one of the panelists wants to comment on this, or we can go on.
No, I think this is very clear, and I think it highlights that it's important to always assess the quality with a scale. And ideally, if you have an automated reporting system, as some do, that it can already be in the system, so you can check, for example, the Boston bowel prep for each segment of the colon. So that's very helpful. So if the doctor who reports forgets, he sees this in the standard reporting way. And that's also a very standard way for somebody else, if you're not the endoscopist, to see afterwards whether all segments were inspected well. I think an important other issue here is that also the endoscopist should put effort in trying to clean, right? So for example, the Boston bowel prep is a scale that's used after optimal cleansing by the endoscopist. And of course, that shouldn't take 1 hour. And if it's solid material, it's impossible to remove. But if there's quite a lot of like darker fluid and you can still remove it, the end situation is the way you have to report it, because that reflects how well the inspection was done.
Perfect. Thank you. So we'll go on to the second case, which is a female of 62 years old who undergoes a removal, endoscopic removal of a homogeneous granular LST of 3.5 centimeters in the rectum with a piecemeal endoscopic mucosal resection in 4 fragments. And the histology is a tubulous adenoma with low-grade dysplasia with isolated foci of high-grade dysplasia. So the question for the audience is, when would they undergo the first surveillance examination and the second surveillance examination? So the polling can start with what surveillance interval would you recommend for this patient? Okay, it's going. Okay, another hint again. So 6 and 12 months after baseline, 6 months and 2 years after baseline, 12 months and 3 years after baseline, 3 years after baseline, or 6 months and 18 months after baseline. Okay, we have a draw among the 6 and 12 months after baseline and 6 and 18 months after baseline. So going on to the answers, as we have seen in the presentations, the first surveillance examination should be done at 6 months after baseline, while the second should be done at 18 months after baseline or 12 months after the first examination. So the last option was correct. I have a question for the panelists. So this is the image of the first surveillance examination in NBI light with magnification on the bottom. So would you perform biopsies in this case if we see that there seems to be no local recurrence?
Ik heb geen overeenkomst.
Okay, so as Evelyn has said, and it is addressed in the advanced imaging guideline, also now we have evidence from the ESGE study and other studies that if you do a very thorough inspection of the scar with using narrow band imaging and near focus, if possible, And if you don't see anything at all, any doubt, then you don't need to take biopsies, because the sensitivity is very high and specificity. However, if there is any doubt, it's better to take biopsies. And if you are not very good on optical diagnosis, I would say to be conservative and to take biopsies. Especially, that is a little bit of my experience, not so much of evidence-based, especially if the lesion was harboring high-grade dysplasia and it was removed by piecemeal, because it can happen that when you remove by piecemeal high-grade dysplasia, and in situ carcinoma can be confounded because the pathologists don't have a well-orientated piece. So it's always better to be a little bit conservative. So if you are not very good at optical diagnosis, you don't have good endoscopes, or if you have any doubt on granulomatous tissue or adenoma or hyperplastic residue, it's better to biopsy. But if you are really, really confident, high confidence, then you don't need biopsies.
Great. So going on, this patient undergoes the first surveillance at 6 months, which is negative for recurrence, and second surveillance at 18 months, negative for recurrence with no biopsy taken. What about the third surveillance examination? This always confuses me. And only in this moment, the patient can be inserted in the surveillance interval, as we as we have seen before. And in this case, the patient has to be seen 3 years after the second examination. Do you agree with this?
I think my colleague Maria has definitely explained this. The patient has had a high-risk polyp, and actually, I think what should be stressed here, that if at the second endoscopy should be, though, a full colonoscopy and not just a scar examination, because if the lesion is in the rectum, the first time what we usually do in my center is just look at the scar. And then if you have a second instance, then I would do a full colonoscopy. So if one of those two was not a full colonoscopy, I would not wait another 3 years. At least that's not according to the current guidelines. So I think that's important to stress.
Absolutely. So maybe we have time for a last case. Which is a female of 71 years old. She undergoes a first colonoscopy for hematochezia. The colonoscopy is complete, and she has one single pedunculated polyp in the sigmoid of 25 millimeters, who is removed. And the histopathology reads intestinal adenocarcinoma in situ that does not surpass the muscularis mucosae. So this may frighten someone. Would I be right to be very frightened about this diagnosis?
Maria?
Excuse me. Oh, excuse me. I was just looking at the questions from the chat, and I got. What was the question, Giulio?
No, the question is just we removed this 25 millimeter pedunculated polyp, and the histopathology says adenocarcinoma in situ, and I got very frightened about this. Was I right about this?
Okay, that is a very important point that you're raising here, Giulio. I don't know for the rest of the audience, but this was something that was quite difficult for me to understand or to accept, like when we started with the screening program and to talk with everybody that was involved in the screening program, because the word adenocarcinoma makes you think that we are talking about a cancer, obviously, so an invasive cancer, but the colon is a little bit different from other parts of the digestive system. It's much nicer, and what we know is that when it's an adenocarcinoma in situ that only involves the muscularis, that is not going through the muscularis mucosa into the submucosa, the risk of having metastasis is 0%, zero. So this is not considered as a cancer in terms of oncology because it can never give you metastasis. So it's similar to a high-grade dysplasia in terms of follow-up. So you have to be a little bit scared, of course, because it's an advanced adenoma, but not as if it was a cancer. And probably now Giulio is going to explain it better than me. Go on, Giulio.
No, I totally agree with you. I would like to highlight, though, that this is also an Eastern way of writing, especially Japanese. This is what they write, because they say, well, the cells are thus this plastic, that it's really a carcinoma, but it just does not invade. So in most of their studies, also for ESDs and for all their advanced resection techniques, they group intramucosal carcinoma in the carcinoma group. So I think this is a very important point raised, and I think you should be really aware of this issue.
Perfect. Yes, and that's why the revised Vienna classification has collapsed the definitions of high-grade dysplasia and carcinoma in situ to non-invasive high-grade neoplasia. And in this case, of course, we have a high-grade dysplasia, and this is a polyp that definitely requires surveillance. As you know by now, we will see him in 3 years' time. So let's try to move on, and we are fast forwarding to 3 years later. The patient is now 74, and she undergoes the first surveillance examination, which is negative after 3 years. So as we have seen before, she goes to the much discussed second surveillance examination after 5 years, and she is now 79. In the second surveillance examination, she is negative. And she asks us, what shall I do? Shall I go on and have a third surveillance examination? And Maria already shows us very well that ESGE recommends stopping post-polypectomy endoscopic surveillance at 80 years old.
I have to say that I found more harder to convince people to stop here than to do not to do surveillance.
Yeah.
This is really much difficult.
Actually, if she was told she had an early carcinoma, she's probably worried as well. So again, explanation is important here, I think, and discussion with the patient to make her understand.
Yes, very brief. So a male patient of 53 years old undergoes another colonoscopy and removes 4 polyps, all under 1 centimeter. All 4 polyps are low-grade dysplasia. I'll go fast. We know that they do not require surveillance. We do know they have to return to screening or 10 years colonoscopy. But as we know, we are in Europe, and Europe has very different rules for this. So we might have to divide the management for the single countries. What do you think about this?
Yes, I already told you. I think this is very, I think we don't know enough here yet. In the Netherlands, what we do in our screening program, if somebody is FIT positive and has a colonoscopy, if that colonoscopy is negative, the patient is sent back to screening, to FIT screening in 10 years, which is actually based on the fact that we think a colonoscopy to protect patients for 10 years from cancer in almost all cases, so except those few post-colonoscopy cancers. However, I think the group in FIT screening might be different because they have a higher risk up front because they have a positive FIT. And second is at 10 years, you don't do a colonoscopy, you don't do the gold standard, but you do a FIT that we know has a probably 75–80% sensitivity for advanced lesions and cancers. So I think the evidence is not there yet. So I don't know what to advise. I think this is when we will take over this guideline in the Netherlands, which we are starting debating at the moment. This is one of the issues that we will try to get data for, to understand what we should do.
We have to add that in Catalonia, the big region where I live, we returned to screening in 2 years instead of 10. We have been doing that for the last 10 years, and we are now analyzing what happens. Like around 20% of patients will have again a FIT positive in the next round. So only a few have advanced lesions. Most of them you may find again small polyps, but you don't have. But I don't know we have to analyze everything. But probably our numbers. I don't know if we will have enough numbers to give an
I'm
answer.
very curious. I'm very curious because I think one of the reasons for a false positive fit is, for example, hemorrhoids, right? And the hemorrhoids will still be there after 2 years. So that's why we decided not to go back to screening immediately. But I look forward very much to your results.
Yeah, actually we analyzed it because the endoscopists in the unit were a little bit mad about it because they were telling me, well, we are doing a colonoscopy to someone that already had one 2 years ago with good quality standards in our unit. Why are we repeating this colonoscopy? So, so we looked at it, and it's only a few ones that you repeat from the whole population, and the findings are not. There are not a lot of findings. But neither, when you have angiodysplasia in the first one, you don't think that you will find it afterwards. That's something that, so it's curious that sometimes the findings are a little bit random, but it will be nice when we analyze the whole population and we give you the data, I think.
Because you do the surveillance earlier, or the new endoscopy, and somebody has adenoma, right? So it's interesting.
Hmm.
Colleagues, please, the knowledge is indefinite. However, webinars are not definite. Giulio, please continue.
We can just have a last look at the last question I wanted to give our panelists, if the system makes me, otherwise, here we go. So, are we more scared about the single high-grade dysplasia of case 3, of the single polyp with high-grade dysplasia of case 3, or of the 4 polyps, small under 1 centimeter, low-grade dysplasia of case 4?
And as we're going to the end of the webinar, this is very good food for thought.
Exactly.
I think the freckle parallelism is very good. You can have a lot of freckles, but I'm really worried about the one that has some not nice features. That's the big difference.
Yeah, Maria, but the polyps are all radically resected. So we are discussing not these polyps, we are discussing the new, the metachronous polyps. So I'm not totally sure, but of course this is what we do in the guideline, but it's not totally intuitive, I would say. Of course, the left one feels like a really hazardous, and maybe the patient will have a new one again, but it will also take probably 10 years or longer to have such a one. So I don't know the answer. It's interesting.
Okay, that's it, I think, for us.
And having said that, I would like to thank you all three. It was a privilege to have you with us. It was a very nice webinar. The topic was very hot. And I would, at this moment, I would like to thank my governing board and the webinars, the ESGE Webinars team that offer us the opportunity to have this presentation. I would like also, thank you, Dave. And I will also like to inform you that, as you already know, all these presentations are stored in the ESGE site, and you can check them out whenever you wish. And for this special webinar, I would like to thank, beyond the governing board, I would like to thank Aohua. Aohua is a new partner. It's a new kid on the block. We have a Aohua company now in Europe. And of course, it's very nice to have new partners to help us in serving our patients. And the time is going by. You're coming to the end of this year. So please renew your membership, the individual members. And if you are not an individual member, please set up an account. The benefits are a lot. And we wish you it will be a great pleasure for us to have you with joining the ESGE to get all these advantages. Finally, before saying goodbye, I would like to remind you that the next webinar will be actually next year. And until then, I wish you Merry Christmas, Happy New Year, and enjoy all the vacation and the holidays. Stay safe, and it was a pleasure having you with us. So bye-bye.
Thank you very much.
Thank you.
Thank you. Bye-bye. Thank you.